Hello everyone, welcome to CAPC Master Clinician Series. Today's faculty are Dr. Andrew Esch and Dr. Sharika Newman. Thank you both for hosting today's session, and thanks everyone on the line for joining us. Please note that if you are dialing in from a telephone, you must enter pound, then your audio PIN, and then pound again to be heard on the call. Your PIN can be found at the top of the GoToWebinar control panel. If you need help at any time or to have your audio PIN resent, simply enter a question in the chat box located at the right side of your screen and I will assist you. We currently have 2 callers on the line right now, but expect a few more to join us. So please introduce yourself the first time you speak. And also, we encourage you to fill out the very brief survey that you'll see on your screen after the call. And Dr. Esch and Dr. Newman, I'll turn it over to you.
Hi, good afternoon. Thanks for joining our first, actually it's our second Master Clinician Series. Dr. Newman and I had done this previously, but it ended up sort of degenerating into a talk about how to build and sustain a palliative care program, which was fun. But this one is going to be a little different than what we've normally done in the Virtual Office Hours series, in that we're going to talk through a challenging case, talk about some of the issues that come up during the case, and we want this to be as interactive as possible. We want to get people's thoughts on how they might have handled things, experiences they've had, and we'd like this to be as interactive as possible with you guys chiming in with your input. So we're going to just start off. I'm going to turn it over to Dr. Newman, and she'll do a little introduction to the case and set the background, and then maybe we'll open it up to those of you on the line and get your initial thoughts and just start the conversation from there. So Sharika, why don't you take it away?
Okay, so as you can see on the screen, we have a case that the palliative care team has been asked to see of a 27-year-old female who presented with generalized edema 3 weeks after a scorpion bite over in the Mojave Desert. She was later discovered to have lupus. She and her mother refused medical treatment and preferred to risk disease progression rather than to experience possible side effects from treatment. And according to clinical staff, they have been deemed difficult, the difficult patient. You and your team on the palliative care team was consulted at day 30 of the hospitalization to discuss goals of care. Is there another slide? If this were your patient, what would you do? And so we can kind of open up the discussion with questions, with what you see is are palliative care treatments in a complex case of this nature, or how would you approach the case at day 30 into a hospitalization?
Is anybody,
Right now,
everybody's being shy.
Yeah, I was going to say, Bina and Caroline, both of your lines are unmuted, so if one of you want to chime in, feel free.
So we can talk about how the palliative care team that had the case approached this case. This very challenging case, if that would, Andy?
Well, yeah, I think one of the things that comes up is, I think a lot of palliative care teams often get consulted on those folks that are deemed difficult by the hospitalist service or whatever service has them on. And I think a lot of times we're viewed as the solution to that. And I think one of the things, I mean, how I would approach this case and how I normally did in my practice was to try to be open-minded and really go in with a fresh perspective of, I'm going to take my own history, I'm going to, meet the folks involved, and I'm going to draw my own conclusions and not go in with a preconceived notion of, okay, these are difficult people that are going to be a challenge to deal with. So that would be the first thing that I think I would do in terms of approaching it. But I'm guessing, Sharika, your team probably took a similar approach.
Yeah, and I always tell my team and the fellows that we train that we, the medical staff, unfortunately don't have a dog in the fight. And so to go in with a biased position or to go in with an agenda is actually unfair from a palliative care standpoint, in my opinion. You kind of have to go in, like you said, Andy, take your own history and physical and come up with your own objectives and your own conclusions about the case and about the people involved in the case. And because we were able to do that, with fresh eyes and fresh ears, we were really able to obtain why they were being what the staff perceived as difficult. No one had really asked the patient what she wanted, and that's part of goals of care, to delineate really what the patient or the patient's family wanted out of this care. It took them a very long time to accept that the edema was not related to the scorpion bite. And it was really a diagnosis of lupus. And so getting to that point took a long time for them to accept or even embrace, more or less accept. And I don't think we would have gotten there if I had gone in or the team had gone in with the position of, oh my God, they're going to be difficult. Let me, get myself together. Let me figure out what to say. Let me, all of that. We just had a pure organic conversation with the patient, who was very, very intelligent and understood what the staff was saying and really had a strong position on what she wanted and did not want.
And what was that, Sharika?
Well, she, they had tried to do an ethics consult. What she really wanted was ongoing treatment on a medical treatment basis, evaluating her own risk and benefits, even for things like IV antibiotics, even for things like steroids or hemodialysis. She had already been in the ICU, experienced a cardiac tamponade, had to get a window, had to get fluid removed for thoracentesis. So she had already experienced a what we call critical illness in the hospital and had all these extreme medical interventions already. And what I've come to realize is that when patients have experienced those things, they kind of know what they want and don't want going forward. So she wanted to, at one treatment at a time, decide if she wanted to do it or not. She wanted to be educated about the treatment options, the risks, benefits, and the objectives. They were very clear that medicine is not linear, that just because you offer me this treatment does not mean the outcome or the intended outcome is going to be met. And so she wanted to piecemeal it together and understood that doing it that way could possibly not benefit her in the long run. Very clear that this is a systemic disease, and therefore treating one piece at a time, or treating this but not treating that, could have an adverse outcome on the back end.
Yeah, so I'm curious to hear what everybody out there on the line has to say about the involvement of ethics in this case. Is there, I guess in your opinion, is there an ethical dilemma? And if there is, what in your words is that dilemma? Somebody give us their thoughts. All right. Sharika, we're just going to keep going then, I guess.
Sorry, can I interrupt really quickly, Dr. S?
Yeah.
I just want to let Melanie know, Melanie, to unmute your phone, you just need to enter #5 £5, and then we should be able to hear you. But Bina and Caroline, you both are unmuted if you do want to chime in. And Melanie, again, you're to unmute, it's #5 Thank you.
When Dr. Newman and I we've actually been talking about this case. Has it been over a month, Sharika, that we first talked about this case? It's one of the interesting things I think in medicine is that when situations like this come up where patients aren't doing what we think they should be doing, or they're making decisions that maybe we don't agree with. It causes a lot of, it makes us feel uncomfortable as providers. And the general way, in my experience, in my travels, that the healthcare system or the clinicians deal with it is to usually get psychiatry or ethics or probably both involved, because we go to this place where, you know, we can treat lupus, we should be treating lupus, you know, this person should not be, you know, refusing these treatments. So the knee-jerk reaction is to get more providers involved and add layers of complexity. But one of the things I think that both Dr. Newman and I agree on is that, Sharika, these are your words, and I feel bad I'm taking them, but moral distress or us not feeling good about what's happening with a patient doesn't necessitate or doesn't really indicate that there's an ethical dilemma. And I think that's a hard place as a clinician to be in, is feeling badly about what's happening or the outcome, or what you know the outcome is going to be, but at the same time knowing that you know, you need to be respectful of a patient's autonomy. So Sharika, how did that feel when you guys were going through that? I mean, you're a pretty experienced physician. Maybe you felt okay with it, but I'm guessing there was people on your team that didn't.
Well, you know, even though I've been doing palliative care for a while, I still kind of feel torn, because where medical and social needs really bump heads. We are right in that gap as palliative care providers, and we're also in a place where we have to please our consultants and the patient and family. And when you go into a case knowing that dynamic or that care coordination is already muddy, I always feel like, oh my God, somebody is going to be upset after this, you know? So it was sticky going in for me, and I could see the moral distress on the team. You know, there are certain nurses who no longer wanted to care for the patient. You know, there was talk about her mom being crazy. They had fired a nephrology team, and now this is the second nephrology team, and you know, her kidneys were continuing to fail because we were not treating the lupus. And I could see that the nephrologist was, you know, felt, I don't know if defeated, I would say is the word. So it kind of, you know, and these are our colleagues, you know, so you kind of feel bad for them. So I kind of felt a little, you know, tug going in and knowing that maybe on the other side it wasn't going to play out so well. We had two large meetings about this case, including the palliative care team, hospital medicine, case management, administrative staff. The chief medical officer got involved. The pastoral spiritual care was involved. And we really had an interdisciplinary meeting, which was probably the most beneficial piece of this case. In that meeting, we talked about the ethics consult and a neuropsych consult, because I felt like we still had not at that time delineated whether this decision-making was based from a psychotic position, like a true psychosis or some mental illness, versus a competent, you know, person found without a mental illness. So they refused the psych consult, would not even let him in the room. And so we, you know, had to continue the case without psych input. But rheumatology never saw the patient, which was a concern of the people at the meeting. And probably like a lot of community hospitals, some of the disciplines won't come to the hospital. So our hands were tied as far as getting rheumatology to see the patient and educate them about lupus. But I felt like we had enough consultants on the case that had educated the patient about the disease and the treatment options, and they just really did not want them.
So even though psychiatry was refused, I know you and your team, we had talked about this earlier, you did depression screening and capacity assessment. And it's also one of the interesting things when quote unquote difficult patients or difficult situations come up is the reliance on psychiatry, I think, to make us all feel better about things. when really there may not be a basis for it. Because, you know, I had a patient once who wanted to stop a feeding tube. It was a vent-dependent patient. He had had a spinal cord injury when he was much younger and just decided he didn't want to live that way any longer. So his decision was to just stop feeding himself. And then when he became unresponsive, he wanted to be terminally weaned from the vent. And before my palliative care team got involved with that patient, he had been seen by 3 different psychiatrists who all said the same thing, that he had capacity to make the decision. But because we didn't feel right about what was going to happen, we kept referring to psychiatry for them to come, I guess, reassure us or make sure we didn't leave any stone unturned. And I don't know that in this case, if you've ruled out, you know, if you've ruled out like underlying depression, suicidal thoughts, and you've determined that this patient has the ability to has the capacity to make decisions, it really becomes a case of autonomy. And medicine in general does defer to the patient's autonomy in making decisions. I mean, those of us in palliative care see this all the time. You know, we even see it the other way when we sometimes have these patients that are on chronic ventilatory support in an ICU, and you know it's not going to go well. But they're just being kept alive, getting procedures done, A-lines and central lines and everything else being done to them, when you know that there's essentially medical futility of them ever having a recovery. But we do those things because we err on the side of autonomy. You know, we have this oath not to do harm, but you can actually argue that we're harming some of those patients in an ICU type setting, but autonomy sort of trumps that. We always respect the patient's autonomy, and that works both ways. In this case, it works the other way. She's exercising her autonomy. We don't like it, and she's exercising it against treatment. And I think in palliative care, we normally see it the other way, where we see these folks that just sort of linger with futile treatment because we respect their autonomy as well. So to me, the issue is the same. It's just playing out a little bit differently. What's your take on it, Sharika?
You know, I completely, wholeheartedly agree. And I always wonder sometimes if we, the medical team, are making it complex by adding more clinicians in to say or do something because we feel a need to do something, and offering treatment that we know is on the border of futility. And that does nothing but complicate the patients and their families. Like, why are we offering a treatment that we know is really futile or not going to get any gain, and then saying that they're making decisions to continue aggressive care, continue restorative care in the face of futility? Well, they would not know anything about it if we didn't offer them the stuff. But I think we as clinicians sometimes feel defeated if we don't offer something. And,
right.
You know, I am, in this case, because we are skilled in palliative care communicating, the patient and family felt like our team was, quote, on their side. And I wouldn't say I was on their side or our team was on their side, but we heard them and we kind of advocated for their position. I did not, you know, personally think it was a good decision either. But because I said, I hear what you're saying, and I will relay it to the team and try to help them understand what you want, they felt like, they actually said, why weren't you guys here earlier? Why did it take so long to get here?
Yeah, that's a common theme in our profession, right?
Right. And, you know, she actually went home under the hospice umbrella. Towards the end of the stay, she decided not to get any treatments, not even dialysis. She wanted the lines removed. Her culture test came back positive, and she did not want them treated. And she went home with hospice and probably died 2 weeks afterwards. It's not something any of us wanted for a 27-year-old. And I want to say that was probably the whole, you know, issue in this case, is we were dealing with a young woman who was chronologically 27 but had a lower emotional IQ. She was very codependent on her mom and had never moved out of her house. And even though she had a master's degree, she had never experienced the world. So it was it was a very tough case for all of us to swallow because we want a 27-year-old to live. But I want to say that they got the care that they wanted. And I think that's our role in palliative care when we talk about addressing goals of care and aligning them with complex medical treatment and care coordination. Is to get people the treatment they want, like Andy says, and don't give them what they don't want.
Yeah.
So it looks like Bina wrote in a message. She says, would there be legal implications if we don't offer because it is supposed to be informed decision making?
Sure. I mean, I don't think the issue here was that she didn't know what her disease-oriented treatment options were. I mean, I think there isn't legal issue there, and Sharika, I'll certainly let you handle this too, but I know Dr. Newman and I have worked together in the past, and a lot of times you'll call your risk management folks just to be sure. I do that a lot. I'm a huge patient advocate. I'm also a huge advocate of covering my backside. So I would say that we have to inform our patients of the benefits and risks of treatments and the benefits and risks of not doing those treatments. And I don't know if Sharika, you did this at Emory or if you even have it or wherever wherever this patient was from, but in the health systems I worked at, we've always had a risk management team that we could call up and get the attorneys on the phone and just say, like, look, this is where we stand. We feel confident. We've given both sides of the equation, and this is what the people are choosing. What's my exposure here? So maybe you can tell us about your experience, Sharika.
So yes, I've always worked at facilities that had risk management teams. And when I say we should not offer treatments, like if someone is actively dying and would not benefit from resuscitation, I don't think it should be offered. I've had risk management tell me that a physician can say they will not do a treatment. And I think sometimes we forget that we have the right not to perform a treatment or not to offer a treatment that we're uncomfortable performing. So I think sometimes the clinicians, and I can throw myself under the bus sometimes, feel like I gotta offer something, I gotta do something, when really we need to be offering comfort care. We would really need to be offering a treatment that really aligns with what's going on clinically along with the goals of care. So there can be, you always want to check with risk management, but you do as a clinician, from my understanding, at least where I practice currently, I've cleared this with them, by the way, I've asked this a couple of times, we have the right not to give a treatment that we think is unreasonable or futile. And if they still want another clinician.
Yeah, that's a great question. Carolyn or Melanie, do either of you have thoughts or comment or question?
Or has anyone ever had a case where the more...
Oh, can you hear me okay? I had muted my own phone. Hey, it's Caroline.
Okay.
I was just saying that, yes, in this case, like you said, from the beginning, if somebody is deemed difficulty, I always believe you got to go on in with your own fresh set of eyes. That's at the very top and see for yourself. And then, of course, I think nurses or clinicians, we were trained to save lives. But just like when the hospice was introduced, there was a lot of hostile and thinking. So I think that we as clinicians also have to be trained, paradigm shift, what our, what rights, what we can do, and things that we're discussing right now that, yeah, we have a right to withhold and not withhold, and sometimes also making sure risk management is involved in any wavering forms that they can fill in to say, yes, we've been educated, yes, we've been told, but we're still choosing not to. I know as a clinician who was trained, my mindset is to save life. If they say no, it's like we cringe, but, we are learning to know that, they have a right to refuse treatment as well. And so I'm saying that, it's very important, yes, to do all that, to involve everything and to offer them everything so that you leave no stone unturned, like Dr. Andy said, so that even if this 27-year-old goes home and say, you know what, I'm not taking nothing, I'm not taking medicine, I don't want dialysis, I don't want all this, we're at piece that we have done all we can, and they are making this very conscious decision, and we have to respect that. But I'm thinking that a lot of clinicians have been trained a lot, because most of us, coming from a hospital setting, in different settings, we still don't fully embrace the fact that we can just let somebody say, you know what, I'm done. I'm so done with everything. Things like that.
I really love that comment. I do, because I think it's one of the key teaching pearls in this case, is that even Dr. Newman and her team did not feel comfortable with what was being done because of what you just described. We don't go into this business wanting to lose young patients, but there's a way that you can still be an advocate for your patient, explain to them both sides of what treatment looks like, what denying treatment looks like, and having them come out of it on the side, having that patient and family feel like you were on their side. I don't know that Dr. Newman and her team said anything different than maybe the nephrologist and the other folks involved did, but there's a way that you can still be a patient advocate and not make it an us against them. Sharika, what are your thoughts about that?
I want to say I think I said less than most people. I think, Andy, we always talk about the silence and how golden the silence is. I think saying less is more in some of these situations, especially at day 30. And I think I started with the whole ask, tell, ask, and just ask what they already knew. Because she was, intellectually savvy, she knew everything. So it was easy for me to go saying, now that you know all of that medically, what kind of treatment you want, do you know that the risk and benefits of it? So it's easy to have that organic dialogue with, our palliative skills and get to the end of it and really understand that she understood risk benefits and she felt like she was always in the 1% of side effects, and that's what she said. She's basically, if I take this Banco, I'm going to end up with whatever that side effect is, that's even 1%, and I don't want that. So I think I said less than other people.
Yeah, well, you listened. I mean, that's what you're doing when you're silent.
Right.
You're listening, and I mean, that's probably the most important thing that we do for our patients in palliative medicine is we listen to them, because healthcare in general. There's a great study. It's probably over 10 years old now, but Mayo Clinic proceedings actually looked at their physicians these were primary care practice people at Mayo Clinic, and they observed them for a period of time to see how long it was before they interrupted their patients, and it was 13 seconds. Like, doctors would listen on average 13 seconds before we'd open our mouths and interrupt people. And you can't learn much about anything in 13 seconds. So, sometimes those silences are the best thing, because it means we're listening and we're giving our patients a chance to talk. How about Melanie? Are you out there and unmuted and have any thoughts, or just listening? Just listening is okay, but just let us know you're out there.
And I'm not Melanie, I'm Caroline again. I'm just saying, you are saying educating even the doctors, sometimes even the physicians, like you say, they don't even give you time to talk. We see that, and I hear that a lot from our Blue Cross Blue Shield members. It's like, my doctor doesn't even listen to me. And that just really it's heartbreaking, because some of the times they miss the real important, if they can listen to what the member is saying or patient, they can actually hit the right diagnosis or whatever. But that goes back to educating us as clinicians and educating the physicians on, when we get into situations like that, how we should just really, know that, we should give them that opportunity to air themselves, to say what they need to say before we even try to label them difficult. And that's what I have noticed in the nursing. If they don't do what we say, then you're automatically difficult. It's like, no, we haven't given them a chance to listen. And that's where difficult comes in. And then you want to know why are they putting this person difficult? What happened? And things. Well, yeah, there are some difficulty, but for the most part, it's usually, you're not doing what we are trying to tell you. You're not giving us, you're not doing the template we are used to, and this thing that we always have, this template. We want to save you, we want to make you get better and all that stuff. And if you are not wanting that, then we want to label you difficult, and that is not right. I was in the hospital and I didn't want a G-tube. I mean, that was the most horrible thing. And I'm a registered nurse. I could not believe G-tube is horrible. And but fortunately, my doctor let me do without it. But I just don't remember. I'm sure they probably called me difficult, but I could not handle it. I just couldn't. I couldn't do that. So, like I say, it's all education, the physicians, us clinicians, to really understand where our members are coming from, and just to paradigm shift. Like we're still like in that life-saving mode, and we should give them the right to say, no, I'm not going to do it. I'm not going to do this. It's just, and then of course we give them everything, like you said, we offer all the, and of course you cover your legal, we offer everything, psychology, risk management, and you cover all stones are unturned. And then both parties are at peace with whatever decision is going to be made, even the outcomes, whatever that looks like for them and for us. Both parties will be at peace. I'm talking clinicians, and I'm talking, the patients as well. So that's what I'm getting out of this, and I'm learning because I'm coming from I got to save your life. I got to save your life mindset. Right?
Yeah, and it's interesting. I think even as a palliative care physician, and I'll let Dr. Newman chime in on her thoughts, but I still, I don't look at patients like, oh, you're inevitably going to succumb to this illness, so we'll not treat this or not treat that. I mean, I have lung cancer patients that get pneumonias, and I treat them all the time. I'm very aggressive with life-sustaining treatments if they're in line with goals of care, and that's what I always have to be reminding myself of, is what are the goals of care, and is what I'm about to do in line with this patient's values and their goals of care. And you'd be surprised that you can still be doing some pretty aggressive life prolonging or sustaining things that are in line with somebody's goals of care who may be a do not resuscitate. I mean, there's a whole lot of gray area that I think you always have to ask yourself about if what you're doing is in line with the goals. I don't know, Sharika, what are your thoughts?
I completely agree, and I agree with Caroline about this whole paradigm shift and how we were trained to treat patients. And I think the whole movement towards patient-centered care, even though it's slow-moving, is where we have to go. Long gone are the days where the doctor comes in and says, do this, this, and this, and the patient says, okay, and walks out the door. Patients now are asking questions. They want to be included in decision-making. And that's part of what you're saying, Andy, is, okay, these are the treatment options. Now, how do these options align with this patient's goals and values? And that is the key piece to me that is sometimes missing off of these complex cases. And that's really what causes us a lot more distress, because we've never really asked the patient what they wanted. No one before day 30 had asked this young lady what she wanted. We were all coming in, ascribing and assigning these treatment options to her and kind of saying, you should do it because it's treatable, you should do this, you should. And so she was feeling unheard. And I think that is the paradigm shift, is to include the patient in the decision-making, medical decision-making, and that's patient-centered care. And because in palliative care, that is our focus, like that we always, looking at the patient and the patient's family as one unit, it comes a little bit easier to us than the other clinicians.
Yeah, that's a great point. Imagine how frustrated this master's level educated person must have felt lying in that bed and having no voice and no say in what she felt like what was going on around her.
With a master's in communicology on top of that, you know.
Yeah.
You know, she's had a master's degree in communication. That's why she was like, where have you been? Because you're the first person to communicate with me.
Yep, had to be really, really frustrating for her. So one of the other things I wanted to ask you, and Sharika, I don't think we've even talked about this yet, but Caroline brought up a good point about education. And as I'm thinking about education in this case, there's so many levels. I'm just wondering what your palliative care team did with this case afterwards, because it seems like there's an amazing opportunity there to then go back and talk to some of the other services involved and maybe educate them some on communication skills or palliative care core principles, or maybe just even debriefing. I mean, going for a coffee and just talking about how even as palliative care doctors, you don't feel great about this patient's eventual outcome, but you know, you did the right thing by her. Have you done any sort of follow-up with others?
We did some debriefing once we got the news that she had passed away. I did a lot of one-on-one debriefing because everyone felt horrible. And I came up with this constant catchphrase that I kept saying, and it was just what Caroline said. You know what? We did the best we could. We can walk away from this case saying, you know what? We did the best we could. We offered all the standard care. We offered the best medical care that we had to offer her. And she made a decision that aligned with that she wanted. And that's what we have to cheer about. We gave a patient what they wanted. So I came up with the phrase of, you know, we did the best we could. We did the best we could. And that's what I started all of the one-on-one debriefings with. Now, the education piece, last year at my facility, we did we used the EPIC curriculum and did a monthly lunch and learn going through the EPIC series. And after this, I said, you know what, we probably either need to repeat that or offer small group settings, because what I've come to realize is me talking about it in a lecture and you actually having to do it is two different things. So we talked about doing either a breakout using Vital Talk, you know, the Vital Talk platform, because one of our clinicians here is trained in Vital Talk, or doing a small group setting where we talk about how to deliver difficult news, or how, you know, to accept when a patient wants something different from what you're offering.
That's excellent. That's excellent. So the communication courses in the CAPC website are actually written by the guys from Vital Talk. So that's actually not everybody's going to have a Vital Talk trainer at their health system or at their institution. So one of the other things you can do with other departments or other providers is, you know, set aside some time or encourage them to look at the CAPC communication modules, which are written by the guy talking. They're really, really good, and everybody benefits from communication skills. I don't care how long you've been a physician or how long. I've been a palliative care doc for 15 years now, and when I took the communication courses, I did poorly. They ask you to respond to a situation, and then they give you an expert response and a good but not great responses, and then some that aren't so good at all. And it's interesting that things I thought I did really well, I had a lot of work to do still. So communications training is really, really important. Any other questions? Sharika and I we wanted to sort of wrap up our part of it by like 2:45 to make sure that we got a chance to answer everybody's questions. So I just want to make sure that you guys get a chance to speak if you have something that's on your mind. So I'm going to give it a second here and just chime in if you have something to contribute or a question to ask.
If this is Caroline again, let's say I have my team, you know, of course I work for Blue Cross Blue Shield, and I have my team, and we want to invite you guys to at least like do a presentation. How does that go about, you know, when we're talking of education? Because sometimes we just start in small steps and address and, you know, and just kind of start that. we were introduced to CAPC by one of our managers, so we did also delivering news and everything. That was our first introduction to the CAPCs, and it's like, wow, this is really good education. So my question will be, like, if we wanted you to do the same, like audio, because I'm doing it on my own, I just responded to it and doing it on my own. But if we really want, if I talk to my manager, or if we want you to speak to our group or team or something like that, how do we go about inviting either you, Dr. Andy, or you, Dr. Newman, to speak to our small groups? How does that usually work through your team?
we can follow up with you after this conversation. Caroline, are you with HCSC?
Yes, yes, sir.
Yeah,
yes.
So we may be able to arrange something where we do a session like this. We could even repeat this session if you thought it would be helpful for just the HCSC callers. So maybe if you had a group together or something, we could probably make that happen. We'd have to coordinate it through Brittany and some of the other people in the education department at CAPC, but I don't think that would be a big issue. So one of us will reach out to you after this today and work on making arrangements for it.
Oh, okay. That would be great. I have our manager, so sometimes we're looking for, like, when we are meetings, what educational pieces can we do? Because we work, I'm a telecommuter, so sometimes our big missing piece is just having to come together and get very informative educational tools like this. And that's actually part of our also DAP, developmental action plans to do. So I'm sure my whole team will benefit from it.
Yeah, and one of the things I think would be really interesting to talk to you and your team about, and I think for Bina and Melanie, this will be a relevant conversation too, that somehow there's probably so much time that Dr. Newman and her team put in on this that within the current billing and CPT coding world we live in, it's impossible to capture that time. So it would be interesting to have a dialogue with you guys on the other side in the payer world of, is there a way that payers and providers work together to reflect the complexity in some of these cases that maybe just doesn't come through, out of the medical chart? Because there's no way to convey the depth of probably some of the interactions that Dr. Newman and her team had in the black and white two-dimensional medical chart. What is that fair to say, Sharika, that there was a lot of emotional and time investment in this?
Oh yeah.
So that actually would be a great dialogue. I mean, there's obviously the issues of what is what's happening to the patient, but there's also the issues of the resources expended on that, and is there a way that we can partner together to? Yeah, well, and not just payment either. Maybe there's something as a provider, maybe there was a way to, maybe there's other palliative things that could have been done if hospice wasn't appropriate. It turned out hospice was appropriate, but just open up the conversation of what are the in-betweens, because I think in medicine we do a really good job with curative care, with people we can fix, and we do a really good job when they're really sick at the end of life, because I think hospice programs for the most part meet a huge need. But there's a gap in there where people are pretty seriously ill and not necessarily getting their needs met. And this patient fortunately was transitioned to hospice. But what if she would have had 2 years before this would have played itself out? Where would she have gone, and what would have happened to her? So, Sharika, that would have been a problem for you guys, right? If hospice didn't take her, she would have been in that gap, and there's very little that we can do as clinicians in a hospital system to get people what they need on the outside, if they're really sick and not hospice. Yeah. So yeah, that would be an interesting conversation.
I'm sorry.
Go ahead, Sharika.
Not that this case needs any more complexity, but she was uninsured.
Yeah.
So she
uninsured.
She was uninsured. So what I'm saying is, if she didn't go with hospice, her outpatient needs would have had a big gap.
Yeah. You know, it's interesting. One of the sort of real disparities in healthcare that exists is that, you know, this statistic is for patients with cancer, but, you know, patients with cancer that are either uninsured or insured with Medicaid die 1.6 times greater increase in chance of death over 5 years than somebody who's insured. And it's really undeniable that even though we probably in the hospital, I would argue, Sharika, that she got the same care that she would have no matter what her insurance was, but there's huge gaps out in the community for these folks if they're you know, if they're not insured. There's very little that can be offered.
I think inpatient, she got the same care she would have gotten in uninsured, underinsured, or insured.
Yeah, I agree, and that's the safety of being an inpatient when you are underinsured or uninsured. But you know, out in the community, there's huge disparities and
huge gap here, and they may not know. And some of them will just say, "Well, I don't have insurance," and that's it. They just put that block right there and not seek any resources. They just put that block and say, "Oh, my insurance ended and termed," and those are the things that we may. My coverage, you know, terminated, and what do I do? And that's just it. And then, yeah, like you said, that creates a huge gap, and we run into a lot of those just with simple things like just diabetes, which will complicate into renal issues and all kinds of complications. Once that gap is there, then even a simple thing then just gets very complicated, because if you diabetes go unmanaged, there goes the kidneys, there goes everything else.
Yeah, agreed. Yep, tough stuff. So any other thoughts? Caroline, if you have other thoughts, or it looks like we lost Bina, but how about if Melanie, if your audio's working, you have any thoughts?
Yeah, I'm trying to work with Melanie, but we couldn't unmute her, but she did leave a comment. She just says that it boils down to the patient's right to choose. So if her fear of the side effects influenced her decision, then we would need to be supportive in her decision. But I also think that if I was in the muck of it, I would have wanted a psychiatrist to say that she was decisional. And thank you for this excellent presentation.
Yeah, and that's really, I mean, Melanie really boiled it down to what it was about, right, Sharika? It's just, this was a case of autonomy.
Yep. Really big case of autonomy.
Yeah. But a lot goes into making sure that those autonomous decisions are being made in a way that you can walk away saying you did everything you did, or everything you could, right?
Right. And not from a place of impairment.
Yeah. All right. Well, thanks everyone for joining. Any last thoughts you have, Sharika or Caroline or Melanie?
Oh, I just wanted to know how often they offer these courses, different case studies. Those are great case studies, by the way. Those great. I love case studies because then it's like really, you know, I mean, we don't get the whole thing, but it's very helpful to do case studies. So how often would this be kind of coming through the pipeline, you know?
Yeah. So this was, we just launched this product. This is a new offering from CAPC, and this was the first call where we marketed it, and it filled up right away. We capped these sessions at 10. Now, 3 showed up, but we've been booked from, I think we booked up like within a couple hours of putting the e-alert out. So then when we saw the popularity of it, we opened up more, which, Brittany, help me out here. I think they're all booked too, but we're trying to do what, every 2 weeks?
Yeah, then we're going to have to add more sessions because, we're booked through June already.
Yeah, so we're going to answer your question, I don't know the answer yet because the popularity of it is such that we're trying to adapt to it. So we probably have to recruit some other faculty so that we can offer sessions, weekly. I think would be ideal. I think that's what Diane Meyer would want to. I had a meeting with her, and if we could do these weekly, I think it would be ideal. It's just a function of making sure we get high quality faculty like Dr. Newman available to talk through the issues with people. So.
Okay.
So
and
yeah,
they'll be called Master Clinician Series, right? Mm-hmm.
Yeah. Yep. Okay.
Master clinician. Okay.
And one of the things I'm hoping to do as we evolve in this series too is actually to solicit cases from members. So maybe you had you or one of your case managers had a really interesting case with one of your members, and you wanted to talk that through. We just have to kind of work out the details of patient privacy.
Correct.
And once we do, once we do that, we'll probably open it up to submissions from general membership, and then have faculty like Dr. Newman, myself, or some of the others within the CAPC faculty world talking through the cases. So a lot more to come.
Correct. Yeah, we have medical case reviews as well at HCSC, so those help with the doctors.
Yeah.
Right. And do we get
Excellent.
like any kind of like attendance kind of showing, not necessarily CE, but to say, hey, I attended and things like that? What piece of that would we show, like I've attended this for an hour, just for...
Brittany, can you handle that one? I'm not sure.
Yeah, so no, we don't provide any like certificate of attendance or anything for these sessions.
Okay.
And is there something she can show that she was at least logged in and engaged? If her
yeah, I can put something together and I'll send it to you after the call.
Yeah, that's a good point.
Okay.
We should probably do that for folks.
Okay.
That would be great, because we are being encouraged, of course not being, but it's a good thing to continue to engage in those kind of informative dialogue with an incentive. We'll put it on our development action plan, because HCSC wants to know we're being broad. We're just not, we're trying to get as much education as we can as we do with members, because, so many facets, like you say. So the more we learn, the more we know, the more we can be better clinicians as well.
Yep.
Moving along.
Awesome.
And of course, we want to put CAPC on the map. We want to make CAPC very popular too with HCSC. We use.
Yeah.
Correct.
Well, we appreciate
it. But I thank you so much. Yes, I do. Thank you so much. This was great. And I happened to be off, but I really wanted it. So I was like, I have to take my notebook. I want to educate myself. And so that's great.
All right. Well, thanks for joining and thanks for participating. We really appreciate it. And
Thank
Dr.
you.
Newman.
You're
Okay.
welcome.
Thank you,
Bye-bye,
Dr.
everyone.
Newman.
Thank you,
Thank you, Dr. S. Appreciate it.
Everyone have a
Thank
great
you.
day. Bye-bye.
And thank you, Brittany.
Bye.
You're welcome. Thank you.
Thank you.